Welcome back to the channel. It's good to be back here behind the desk, and I have a lot to tell you about. Today, we're going to talk about the Thailand Myocarditis study. It's out now on my Substack post. I've read the paper. I want to put it in context for you. But before we do that, I just want to point out that COVID absurdity is not unique to this country. If you take a train from Geneva, Switzerland to Venice, Italy, you will have to go unmasked for the first 3.5 hours. There's no mask policy. And then when you cross that border in Italy, everyone has to put on a mask for the remaining 3.5 hours. So after sharing the air in the cabin, that car of 100 people, we suddenly put our mask on. On the way back, of course, the mask policy switches again. And the moment you cross back into Switzerland, you can take off the mask. And I happened to see an Italian gentleman. He was wearing an N95 or a KF94, some serious mask. And the moment we crossed that Swiss border, I saw him pull it off one ear, pull it off the other ear. He crumpled it up in his hand, and he threw it in the trash can right there. And then he took a deep breath, and he smiled. And that's really exactly what happened. Swiss stores, of course, have a 0.0% masking rate in the store. But San Francisco, of course, is about 50%, ranging from cloth masks to an N95 mask, and all things in between, like a surgical mask, below the nose, all sorts of things. So these are just some interesting cultural contrasts. But you're not here to listen to that. You're here to hear about the Thailand Myocarditis study. And this is something that I took a look at. I put it in context. I think there's a lot of people out there who haven't fully understood the implications of this study. Let me unpack it for you. First, the goal of vaccination. I don't know if people have forgotten. The goal of vaccination is to protect people from bad outcomes, bad infections, as safely as possible. It's really both. It's doing it to protect them, but you want to be as safe about it as possible. The second goal of vaccines is that getting the vaccine and its side effect profile should not be comparable to the harms of the disease. Vaccines are much safer than getting the disease. Proof of that is polio, which apparently is now in New York City sewers and London sewers, and that's terrible. And I think that's a problem that's in part due to the singular focus on COVID-19. We have neglected routine childhood immunizations. We are now facing the threat of polio. We have only an 80% vaccination rate in kids under 5 in New York City for polio. That's a product of keeping them out of pediatrician's office, pediatricians not doing in-person visits, focusing so much on the COVID vaccine that we've forgotten routine immunization, which has a much better and long-standing evidence base. It's terrible that this is happening, that we're seeing an outbreak of polio. But it's not entirely surprising when you shut down the world for a big period of time to combat COVID-19. The Thailand myocarditis paper. So, we know the goal is to vaccinate as safely as possible. And if you're 80 years old and this is January 2021, and you've never had COVID-19, and you see the initial studies that come out from Pfizer and Moderna, it was a no-brainer in my mind that the benefit, particularly in terms of severe disease, which was seen in the Moderna study, even in the original press release, and the ultimate published document, an extremely skewed rate of severe disease cases, it was a no-brainer that for older, vulnerable people, the benefit of the vaccine is going to be colossal, perhaps one of the greatest medical achievements. It's going to be never outweighed by any known or unknown safety signal. It's also the case that as you descend down the risk gradient and you get to younger and younger people, it's still an important thing to do, but if there is a safety signal, we have to take that seriously and think about ways to mitigate it. And we learned by February, the initial reports came out from the Jerusalem Times in Israel, and we learned into March and April and May, more and more reports that myocarditis is an important safety signal. That's inflammation of the heart muscle. It occurs typically in boys between the ages of 12 and 30, that group, and probably the peak age is 18 to 24-ish. It's worse with Moderna than it is with Pfizer. It's worse with dose 2 than it is with dose 1. And the spacing of the doses matter. If you get the 2 doses on a 21 and 28-day cycle, you will get a higher rate than if you were to space it out. That's data from Ontario province. We knew all this. The moment this safety signal was known, what are we supposed to do in response? Are we supposed to say no one should ever get vaccinated? No, that's not the right answer. The answer is you have to be very careful about weighing the risks and benefits and think about ways you can preserve the efficacy and possibly mitigate or minimize the harm. And there were a number of things we could have done. We could have done studies of spreading the doses further apart. I think that's a no-brainer thing to do. We could have limited the use of the Moderna product in men under the age of 40, for instance, and that's something that was done in other nations that wasn't done in this nation. We could spread the doses. That was ultimately done by the CDC, but it took them a long time before they gave you any flexibility in spreading the two doses apart. We could have also done randomized controlled trials, non-inferiority studies, or even uncontrolled studies of lower doses. Why 130 micrograms? Those are arbitrary numbers that came out of a very quick drug development. We could have tried lower doses to see if kids still had a robust immune response and protection against what we care about, severe disease and hospitalization, without getting the rates of myocarditis that may be dose dependent. We don't know. We could have done those studies. But to do all these things, experimenting around how to deliver it more safely. And then the other thing is you could consider maybe a one-dose strategy. You could consider that for people who've already had and recovered from COVID, maybe they need different guidance. There are all sorts of things you can do. But in order to do that, to preserve and maximize the efficacy, but minimize the harms, you have to take safety signals seriously. We didn't see that. We have a Reuters report where Rochelle Walensky said, we've looked in 200 million cases specifically for myocarditis, and we have not found that signal. I don't know what to think when I hear a statement like that, which has to be incorrect. That had to have been there in that signal, and certainly it is there. We know that to be the case. Now, when Pfizer received EUA for younger ages for the Pfizer vaccine, they had a post-marketing commitment. And the post-marketing commitment was, we are already getting through passive surveillance some measure of the rate of myocarditis, the number of people who are presenting with chest pain and they're getting troponins after dose 2. We're going to get some estimate. And we have many estimates from Hong Kong, from Norway, from Ontario province, from VAERS, many different estimates. The Israeli estimate was 1 in 3K to 1 in 5K in the original reports, and that was documented in Nature or Science in a journalistic page. We have many reports of that, but what we don't know is how much of the iceberg is hidden. How many kids in this age group have subclinical myocarditis? They may not have felt pain enough that prompted them to seek medical care, but they nevertheless have some myocardial damage, potentially detectable by cardiac biomarkers such as CKMB and such as troponin, high-sensitivity troponin assays. That was Pfizer's post-marketing commitment. They have 2 commitments. I have in my Substack piece detailed those 2 commitments. They vary by age group. They have different years for when that data is due. One is due by December 2022. One is due in 2024. That's my first problem. They gave them too much time to complete the post-marketing commitment. What we're asking is to take a group of kids, 500, 1,000, and just draw troponins after dose 2, after dose 1, do EKGs before and after. Let's get a sense of what's going on. What's the subclinical myocarditis? You don't need a couple years to do that. You really need 1 month to do that. This is something that by the time you generate the post-marketing data, the point will be moot. All the kids will have been vaccinated or chosen not to be vaccinated. They'll have made their choice. We need this data in a more expedited fashion. This is something the FDA always does. There's a big body of literature on the rate of completing post-marketing studies. I would refer you to an excellent paper by my colleague Steve Woloshin from Dartmouth that was in the New England Journal of Medicine documenting the poor enforcement of post-marketing commitments. The other thing you can look at is 2 Government Accountability Office reports. I think the last one was in 2009 that again document a pattern where the FDA is not very rigorous about making the companies generate post-marketing data. This is an incredibly important post-marketing study. So, if Pfizer is not going to do that in a timely fashion, who could do it? Well, NIAID could do it. The CDC could do it. Any number of U.S. investigators and hospitals could do it. But none of them did do it. What's really the first remarkable thing about this Thailand preprint, which is a preprint, is that it's in Thailand. Why are we relying on a Thailand study? Kudos to the investigators. People in Thailand do great research. They have great scientists there. Nothing but hats off to them for doing this. But it says something that we have to rely on a Thailand group of investigators to generate data that could have been generated in one of 1,000 hospitals in the United States. It is a failure of U.S. drug policy to not take safety so seriously that we didn't compel this data to be generated in a much faster time frame. That's my first point. The Thailand study is what we wanted. It is a prospective study. You just take the kids as they're coming in. In this case, there's approximately 200 boys and about 100 girls. And as they're getting dose 2, they all got dose 1 Pfizer. It went smoothly. If they didn't go smoothly, they didn't go to the study. They all got dose 2. And before and after, they had EKGs done, and they had cardiac biomarkers, 2 enzymes that are typically elevated when there's cardiac damage. Okay, that's what happened in this study. Now, many commentators on Twitter and other places where people don't know how to think, they focused exclusively on the EKG findings, and they said things like that these EKG findings that occur at some frequency are also seen normally, and we don't know that they're pathogenic, and we don't know that they're due to the vaccine. Sure. Forget about the EKG findings, okay? you can't get so hung up on that you miss the forest for the trees. You should look at the cardiac biomarkers. That's the interesting finding here. And what they find is there were 3 kids out of this cohort, all boys, who had arguably clinical myo or pericarditis. They had elevated troponins and they had all the sorts of pain and features, and one of them was hospitalized, probably required ICU stay. His troponins went very, very high. They had 4 other kids who had remarkably elevated cardiac biomarkers, higher than the upper limit of normal. Somebody said to me that, well, it's possible that those 4 extra cases are artifact, that they are false positive results. And look, if this were the only study in the universe that ever showed this, and we didn't have the clinical syndrome and we just had the 4 incidental troponin, I would be happy to say, I don't know for sure. It might be an incidental finding and a false positive. But you already have the tip of the iceberg. You know that there's a clinical syndrome here. It would defy logic and medicine and biology that were there not to be any subclinical disease. There has to be some subclinical disease. And what this study finds in this prospective analysis is that the rate of myopericarditis in boys is roughly, when you include subclinical disease, which is people who had detected on troponin who may not have felt anything, it's roughly 3.5%. And that is roughly 2 orders of magnitude higher than the documented rate of myocarditis that came out of all these passive surveillance systems. And that ratio is roughly the same as what had previously been documented with the smallpox vaccine when they were forced to do a subclinical study. Now, what does all this mean? It means that this is very likely to be, I think, a real signal. What is the exact magnitude? I don't know. I think it needs replication. In fact, the people who should be doing it is Pfizer. It's a post-marketing commitment, and we need them to put that data out there fast, and the FDA should enforce that. In fact, Pfizer can put it out as a press release tomorrow if they so chose. There's no reason that should be delayed. So we need to replicate this, find the exact frequency. But this is an important signal. So many people want to dismiss this signal. You are playing a very dangerous game when you are so bullish about vaccines. You're unwilling to think about safety signals. No one is saying you should never vaccinate anyone ever. No one is saying that. We want to vaccinate people as safely as possible. We want to protect adolescents and young men as safely as possible. The risk benefit to them for the 3rd dose, 4th dose, 5th dose, who knows how many doses will come, might be different than an 85-year-old. It's not crazy to think that they need a different recommendation. In fact, that's called medicine. Medicine has always been personalized. It's always been tailored to the unique person in front of you. You can tell apart 20-year-old men from 80-year-old women, last I checked. And as long as you can tell them apart, they might need different strategies. We don't need a one-size-fits-all strategy. We don't need to make it so simple that it's dummy-proof. We need to do what's right, And so that might mean different strategies of vaccination in the younger age groups. So this is an important study. It is the first prospective biomarker study of a group of adolescents. And this was, of course, 13 to 18. It wasn't even 18 to 26. One can wonder what the myocarditis is going to be in that higher age group. It was exclusively in boys. It's validating that gender difference. It's 2 orders of magnitude higher than the published VAERS estimates. I don't think that's exactly the right number, that 3.5%, but I think it's roughly in the same ballpark because that's what we saw with smallpox as well, smallpox vaccination. So you got to take safety seriously. Many of the people who are dismissive of this safety concern were the same people that when we learned the adenoviral vector vaccines, Johnson & Johnson and AstraZeneca, had the rare and unpredictable side effect of vaccine-induced thrombocytopenia and thrombosis, or VIT, which led to platelet activation, runaway platelet activation, and horrific blood clots, including in the cerebral venous sinus, that led to even brain herniation and death in some people globally. When we learned that safety signal, there were people like me who took it very seriously, and I've written a number of articles that came out contemporaneously where I said that safety signal is so important, and this age group is a different demographic. It was women between the ages of 18 and roughly 40 or 50, that demographic should be prioritized for mRNA vaccination. They should not get J&J. And then when I learned more about it, I thought that there should just be a blanket hold on J&J. Pending a further investigation of this, we had alternatives. We needed to vaccinate, but safely. We didn't need to vaccinate unsafely. And yet, many people, many pundits, they thought they were being helpful. They likened VIT to women taking oral contraceptives and getting a blood clot in the leg. They said that VIT is much rarer than DVT from taking OCP, so you ought to just roll up the sleeve and get the J&J. That was a very dumb thing to say. It was dumb in many ways because runaway platelet activation and thrombosis is not the same as a benign venothromboembolic event, VTE. It's not the same as that. It is a much more severe and catastrophic problem. It's a terrible problem. those of us who are hematologists, which I am, have seen many cases of HIT, heparin-induced thrombocytopenia and thrombosis. We know how difficult it can be to tame runaway platelet activation and clot. This was a catastrophic problem. Some people wanted to subtract rates of cerebral sinus thrombosis from the documented rates of VIT, but they didn't understand. You only subtract a baseline rate when it's the same entity. There is no entity of VIT with CVT because the baseline is 0 because it doesn't exist in the absence of vaccination. Okay, so that's an important point. They didn't even understand. They were subtracting one thing from the other that wasn't even the same thing. It was a spontaneous cerebral venous thrombosis that wasn't in the setting of runaway platelet activation. They did such a disservice around VIT that it actually led, I think, to a 1-year delay from the FDA actually downgrading the EUA for Johnson & Johnson, which led to unnecessary harm. People were unnecessarily exposed to this product when they could have gotten an mRNA product. We were no longer supply constrained, even at the first moment of it. So what's my point here? My point here is that we can't have amateur hour, okay, when it comes to drug safety. And we have a massive case of amateur hour. We have a number of people who are not academics. They don't read published literature. They don't read papers. They don't think about pros and cons. They don't understand evidence-based medicine. They're not professors. I don't know what they are. They're just doctors who want to do some good in the world. And I get it. And pre-COVID, they were good influencers, so to speak. They picked issues that were sort of indisputable. Kids should get MMR vaccines. That's good. Kids should get polio vaccines. Those are indisputable good issues. Cupping might not work. They picked these sort of indisputable good issues and they kind of kept hammering on that. And they were good communicators for these very settled science issues. But they have proven themselves to be a big problem when it comes to live scientific debates and issues and novel products that don't fit the same heuristics. A novel COVID vaccine in this age group may not fit the same heuristic as a tried and true vaccine that's been around for a quarter century. It may not fit the same heuristic. Of course not. You need some thoughtful people, such as my good friend and colleague Waleed Jalad from the University of Pittsburgh, and such as my friend Venk Murthy from the University of Michigan. John Mandrola, I think, has been excellent on this, the cardiologist. And a number of thoughtful people. There's more thoughtful people than I can evoke because they're thoughtful behind the scenes. It's a very difficult place to sort of articulate a framework because you're navigating a boat through two sets of rocks. The rock of too much and irrational skepticism and irrational fear-mongering, and also the rock of irrational exuberance and ignoring and minimizing real safety signals. These are two rocks of irrationality, and we're trying to guide this boat through. I hope that sense and evidence-based medicine will survive this voyage. I'm not so sure. All right, I think I've discussed many of my points. Let's talk about the implications from this. What are my take-home implications? I have a few, and I think it's worth talking about. 1, boosters should not be mandated without robust randomized control trial of benefit to others going forward. When we get into this fall booster, you can't mandate this in college campuses. You don't know that it halts transmission. You don't have that ethical prerequisite to mandate. You ought not do that. You also, number 2, you need to run large randomized control trials or at least have really robust collection systems to ensure that there is a net benefit to the recipients, especially when you get to those ages of 16, 17, 18, 20-year-old boys. I think that's important. Every time you change the spike protein construct in your mRNA, you might get less myocarditis. This bivalent Moderna booster might have less myocarditis, but it also might have more. We know that spike is implicated in this process. We know it's not mRNA, but spike because Novavax has it. Novavax has it pretty badly. It has a high rate of myocarditis, so much so it was found in the clinical trial. Using antibody titers to make these decisions is a fool's errand. Using emergency use authorization, continuing to lean on the EUA, which is really no longer appropriate, should only be done for people who are currently in nursing homes. We can't use EUA for broad population vaccination anymore. We don't have an emergency. I think we have an uncoupling from death in cases, as we've seen with BA.5. We no longer have the case for EUA authority. It needs to be rescinded. We need to use the more traditional BLA pathway. That's the biological licensing agreement. I think the CDC needs to issue a mea culpa. They need to get on their knees and apologize. You will not be able to heal the damage that's been done unless you take accountability for the many errors, one of which is natural immunity. I see now the CDC is finally saying that natural immunity is treated equivalent as vaccination. Of course it is. It has always been that case. We need to have different vaccine policies for people who've had and recovered from Omicron. We don't know for sure that they're benefiting from additional doses as we might know from people who have not had it. That's an important point. I see people talk about that Singapore study in kids between the ages of 5 and 11. Singapore, in that study, excludes anyone who's had and recovered from COVID-19, which is in diametric opposition to the United States, okay? So that's not a very relevant or generalizable. It has no external validity to what we're dealing with. I want to end by a quote. This is a quote from Anish Koka. He's a cardiologist in Philadelphia, and he's written a detailed post on this. In my post, I linked to his post. You can check it out. He writes, quote, I can assure you and the mostly ER doctor contingent on Twitter that bays about quote-unquote mild myocarditis that there are no cardiologists who want to see their child have a cardiac troponin that is 2 times normal or 40 times normal after administration of some therapeutic. What exactly does one do with an adolescent who had a troponin 2 times normal that is asymptomatic? Given the theoretical risk of malignant cardiac arrhythmias, I would imagine most cardiologists would follow the current guidelines for myocarditis and advise against strenuous cardiac activity for some months. Sudden cardiac death in young athletes is obviously a fearsome complication that is very real and is likely some proportion of sudden cardiac death is from subclinical myocarditis. What is he saying? I mean, I think he's saying a very important point, which is that the more we're aware of this problem, you're going to have to counsel people about it. And how will you counsel them? It's not a simple issue. It's a very thorny issue. And I think he's quite clear that, this is not something to be dismissed to dismiss. You can keep talking about your sinus bradycardia, sinus tachycardia, and say that those things are normal, etc. This is not about the EKG findings. We're talking about biomarkers, okay? And it cannot be a false positive because we have a tip of the iceberg, because we've seen this exact same ratio in another vaccine. I think the Bayesian in me thinks that it's highly unlikely that that would be the case. So my overall thoughts are this paper is an important paper. It's the first prospective biomarker study in an important demographic group. It shows that the boys are in this group are the group that you have to worry about, not girls. That confirms other observations. It is a shame that we have to rely on Thailand for this data. Kudos to the investigators, but it is a damn shame we have to rely on Thailand for this data. It should have been generated by the United States. The fact it wasn't generated by the United States means that we are taking authorization very seriously. We're not taking safety equally seriously. That's not good medicine. You've got to take both very seriously. You can have fast EUA as long as you have a rapid correction of anything you find and untoward safety signals. Accelerated approval, EUA, it is a social contract. And the contract is in exchange for rapid approval, you will take very seriously things you learn after the fact. That contract has been broken many times. You can read my 2 books, Ending Medical Reversal and Malignant, where I describe how that contract is broken in other settings. And I think it is broken here. End of story. So those are my thoughts on this issue. My last thought on an unrelated topic, but kind of related, is I see Dr. Lena Wen, who is a George Washington, emergency medicine doctor and professor. She's the former commissioner of Baltimore City. She is the former past president of Planned Parenthood. She is, to my knowledge, a progressive Democrat. And throughout the pandemic, I've disagreed with her vehemently and frequently. I think, and I cite online, that she has written a Washington Post op-ed in the fall of 2020 saying that perhaps we should keep schools closed for much longer. You know me, I've written an op-ed, actually, that came out arguing that schools should almost always stay open with my colleague Vlad Kogan from The Ohio State University. Very shortly thereafter, we've always had the opposite point of view, that schools were a tremendous good. We should never have closed them. Maybe it was okay to close for 6 weeks, but we should have reopened by the summer. We certainly shouldn't have let it drag on and on and on. And what has happened is a huge catastrophic problem. Okay, I've disagreed with her. Okay, when I saw that she had written an article I disagree with, you know what I did? I wrote an article that I agree with and tried to push my message out there. And I think history has vindicated our position. I see now in recent months, she's coming around, I think. She's more on the side of that we need to have, restrictions insofar as they make sense, but we need to get back to normal. COVID is something we have to live with. It's an endemic virus. She's more close to me. She's not quite exactly where I am, I think. She's still one step to my, she's more precautious than me in ways that I think are not evidence-based, etc. I still disagree with her is my point, but she's closer to me than she was before. She was invited by the American Public Health Association to sit on a panel to discuss COVID policies. There is an outcry against her that she should be disinvited because she has harmful views and, et cetera, et cetera. And this to me is such a problem in the academy. She agrees with the American Public Health Association like 95%. She's a progressive Democrat. I assume that most of them are too. I'm sure she agrees on issues of abortion and issues of healthcare and all these other sort of important issues. She disagrees with you just a little bit. Just a little bit she disagrees with you. And you don't even want to have her on the panel. What's she going to do on the panel, okay? What's she going to do? She's going to come and sit on the panel, and maybe She might say something that says, hey, that's an interesting point. Or maybe you won't be persuaded by her. Maybe you'll find her arguments to be lacking. But maybe somebody else on the panel might persuade her and her next op-ed might not be so bad. She might reveal that she's not a caricature. She's a three-dimensional person who has complex ideas about issues that are changing over time. And I've disagreed with her in the past. I think she was wrong then. I think she's getting closer to being right now. That's okay. I didn't waste my time harping on her. I decided to push forward with my own agenda. My agenda, you see. I mean, I think I've written 100 op-eds in different news outlets. Every outlet, I think. Maybe with the exception of the New York Times, but WAPO and Newsweek and Stat and so many. And then I started a Substack, make videos. I push my own message because I'm a policy person too, and I have my own point of view. I don't dwell on what she's saying. I push my own message and advance my own cause. And I really wonder, why don't her critics just do that? You don't like what she says, fine. You don't like her op-ed. Write your own op-ed. What's stopping you from writing your own op-ed? You want to protest a meeting because she's there? She agrees with you like 90% on all these issues. You do understand that there are people who agree with you like 4% or 5%. There are people who really severely disagree with you. And you want to fight amongst yourselves? The 90% agreement group? I never understand it. I think it's really pathetic. You're an academic. These people who are protesting, they're academics going to an academic conference. You're so sensitive that you cannot even expose yourself to someone who disagrees with you 10%? What type of academic are you? Do you take ideas seriously? Do you take dialogue seriously? Do you take debates seriously? No. And then they say horrific rhetoric that her ideas are killing people. That's horrific rhetoric to say because you do understand that from her point of view, your ideas are leading to greater harm. She disagrees with which policies accomplish the greatest good. That's the whole disagreement. She doesn't want bad things to happen to people. She just disagrees about what minimizes harm. And I disagree with her too a little bit. I think that we should be even less restrictive, especially for children. We should have reopened schools. I think we need to take vaccine policy much more seriously and safety much more seriously. We have to have different policies for 85-year-olds as for 15-year-olds going to college. I think these booster mandates are ridiculous. We all have different points of view. We don't disagree on the goal. We disagree on the data and we disagree on the evidence to get there. And don't you think that your rhetoric, that her ideas are harmful, is really inflammatory and even puts her at risk? To go there on stage, as we see at a time where being on stage leaves someone very vulnerable. I think it's terrible. I'm very disappointed to see academics complain about a speaker who disagrees with them 10%. That's a sad and impoverished view. You're not a real scholar if you can't put up with a little bit of disagreement. And if you really think you're right, you need to take your ideas and get them out there. That's what I believe in. I publish a peer review article, and I'll write an op-ed, and I'll write a stat post, and I'll write a Substack post, and I'll do this video, and I'll make a podcast, and I'll do all these things. Why? Because I believe I'm right on these issues, and I'm going to use all the forum to do it. And I'm not going to waste my time focusing on people I disagree with. They're a distraction from my mission. My mission is to deliver what I think is the right idea. So I think this Thailand study, very important. I think that cultural differences, really important. I think protesting Dr. Lena Wen, pathetic, really pathetic, especially in these days after the horrific things that happened this week. Those are my thoughts. This is the channel. You're back. We're back at it. I have some other videos coming soon. I got some news. I got promoted. I'm going to do a little video on being promoted. I wrote a Substack piece on that. I'm now full professor, and I'm going to talk about what I think that means. How I think it's not an accomplishment; it's a tool to try to do something else. And so that's going to be the theme of one of my future videos. I want to do a video about my everyday carry. I always see these YouTubers talk about all the things they carry every day. I'll tell you what I carry every day. I think you're going to find it really interesting. And someday, if I'm feeling cheeky, I'll do a video a day in the life. But it's not really my style. But I see that that's a very popular. Oh, and then I wanted to do a video on how I study, or at least how I used to study, because I see all these videos of people how they study, even videos of like 7 hours of somebody studying. It's insane. Who would watch such a video? But I'll show you the video of how I used to study. It might bring back memories for those older folks out there. All right. On that positive note, we'll be back. Future videos. Like, subscribe, comment, leave a message below. Subscribe. Recommend the video to a friend. Recommend the channel to a friend. Listen to the podcast plenary session. It's got a lot more oncology stuff. Listen to the podcast VPZD, where my friend and colleague Zuma Damani and I hammer out these issues. Read the new Substack called Sensible Medicine. We've got a great group of like so many different doctors and public health experts and policymakers writing all sorts of different ideas. We've had a pro-con debate with myself and Dr. Adam Sifu. Read my Substack, Vinay Prasad Observations and Thoughts, and leave a comment below. And until next time.